Good morning, everyone. My name is Lindsay Wolfson. I'm so grateful you're here to join us today for this webinar about women's chronic pain and prescription opioids. We are going to get started. And I just wanted to give a little bit of a reminder. I know all of us are now quite familiar with Zoom, but just for those who are returning back to webinar format today, we, for this webinar format, have everyone muted and videos off. We have a Q&A function, so if you have any questions, please put them into the Q&A box and we will answer them at the end of the webinar. In the chat function, we will put links into the resources that we'll be referring to as we go. And if you have any questions, we have some colleagues here. You can message either the producer, Doug, or our colleague, Ella, in the background, and they can help you with any tech issues that arise during the webinar today. As we dive in, I just wanted to provide a brief overview of today's webinar. We're going to, of course, start with an acknowledgement of the people and land, go over the project aims and the key findings as part of this 2-year project that was funded by Health Canada, and then talk about a number of resources to support your practice. Before we begin, we want to acknowledge that we are joining from the ancestral, traditional, and unceded territories of Indigenous peoples of Turtle Island. We want to begin by acknowledging First Nations, Inuit, and Métis peoples as the first inhabitants and traditional custodians of lands in which we live, learn, and play. Today, I'm joining from the traditional territory of the Anishinaabe, Wendake, and Wodsento, Haudenosaunee, Mississaugas, and Mississaugas the Credit First Nation. My colleague Liv, who will be co-presenting with me, is joining from the traditional territories of the Anishinaabe, Kainakekawa, and Omanigig peoples. We pay our respects to the elders past, present, and emerging from the territories in which we are joining, as well as the different territories in which we've gathered for parts of this project. We also want to put our hands in the air with gratitude and thanks for the Indigenous women who've been part of this work to date. So some of you on the call might be familiar with who we are, but I just wanted to start with giving a little bit of an introduction to who we are at the Center of Excellence for Women's Health. The Center of Excellence for Women's Health, we're in our 3rd decade of research and knowledge exchange, really dedicated to improving women's health. And we continue to pursue this goal of closing the loop between research and practice around social change and health improvement for women. And I think you'll see a lot of that, those efforts to close the loop with what we'll talk about today, starting with research and then bringing in all of these resources for practice. We are so lucky to collaborate with researchers, service providers, policymakers, people with lived and living experience, and community-based advocates across Canada and internationally. And we lead collaborations through online research networks, virtual communities, and in-person and web-based collaborations. And so we're really guided by these approaches that are on the screen here to encourage and contribute to the building of sex and gender science to improve or redress the gaps in women's health. We use sex and gender-based analysis to identify differential impacts of gender norms, identities, and stereotypes in the health and well-being of women, girls, men, boys, and all gender groups. And we really aim to for gender transformative solutions that increase gender-specific knowledge, undermine gender stereotyping, and reduce gender blindness. And you'll hear us talk about a number of these approaches as we walk through the webinar today. We also can't have this webinar today without talking about our team. So as I mentioned, my name is Lindsay Wolfson. I'm the research manager at the Center of Excellence for Women's Health. And beyond my role as a researcher, I'm also somebody with lived experience of chronic pain. And I am so honored to be here co-presenting with my colleague Liv, another researcher on this project.
Yeah, I'm Liv Schultz. I'm also a researcher and knowledge translation assistant at the Center of Excellence for Women's Health. Like Lindsay, I'm someone that lives with chronic pain and has for well over a decade. So being a member of and a researcher on this project has been so rewarding and valuable for me. Yeah, we just wanted to take the time to thank our research team for their contributions on this project, some of whom are here and joining us today behind the scenes and attending. So we're grateful that they're here, but also for all of the things that they have done. They might pop in at the Q&A section. We also wanted to recognize the financial contribution for this project, which was provided to the Center of Excellence for Women's Health by Health Canada's Substance Use and Addiction Program. And lastly, our partners. We had 7 amazing regional partners, including the BC Association Pregnancy Outreach Programs, BC Mental Health and Substance Use Services, BC Society of Transition Houses, Victoria Faulkner's Women's Centre, Blood Ties Four Direction Centre, Yellowknife Women's Society, and the YWCA Yellowknife. And we worked with national partners, including AFMC, on the continued development of this work. So we're just so grateful for everyone who's been a part of this. The state of chronic pain in Canada. So pain is one of the most common reasons for Canadians to seek healthcare. 1 in 5 Canadians live with chronic pain, and women are most likely to report experiencing, or more likely to report experiencing chronic pain than men. In 2019, the National Pain Strategy was published to provide a foundation for a national approach to pain management. In 2020, a second report was issued to reflect stakeholder consultations in the context of both the opioid crisis and the COVID-19 pandemic. Finally, in 2021, an action plan was released that targeted information for healthcare professionals and the public and accelerated knowledge translation and research investments. These all help set the stage for the work we have done on this project and emphasize the need to integrate sex and gender science and a sex and gender-based analysis approach in all actionable goals, which is what we were trying to do with this work. So as I mentioned, women report more chronic pain than men and are more likely to be prescribed opioids and rely on prescription opioids rather than illicit opioids to help address their chronic pain. Chronic pain disproportionately affects women, seniors, people living in poverty, people with mental health and substance use disorders, people with disabilities, and those who have experienced trauma and violence. Sex and gender remain important considerations with prescription opioid use. For instance, the impact of female hormones on pain processing may increase the vulnerability to opioid use and misuse and the susceptibility of side effects, which we'll talk about more later. We also know that women who use prescription opioids are more likely to have high rates of coexisting mental health issues, greater rates of family dysfunction and child welfare involvement, and higher likelihood of both use and risk of relapse in efforts to cope with chronic pain, trauma, and other life circumstances. Chronic pain for women is related to experiences of violence and trauma, along with higher levels of sex-specific chronic illnesses and conditions such as fibromyalgia and endometriosis. The prescription of practices of opioids to women are also not well documented and may indicate a lack of consideration of the sex-related physiological sources of women's chronic pain and gendered factors, such as stigma, which we'll talk about, that affect how healthcare providers interact with women. These combined sex and gender-related factors emphasize the differing impacts for women with chronic pain, as well as the need for specific approaches for women with chronic pain who use prescription opioids. Our project sought to explore these gender and sex-related factors.
So that really sets the stage of where we started. And, we've done an introduction to who we are, but before we go any further, we just wanted to launch 2 polls. And the first is really to see who is in the room with us today. So it's great. We're seeing that there are a number of researchers, service providers, people with lived and living experience, a few policy folks, and we'll definitely talk about policy as we end the webinar today, and then some in the other categories. That's really wonderful. Such an array of folks. And then we have our second question, which is really about confidence to integrate sex, gender, trauma, and equity considerations. And lots of mixed confidence there, and that is wonderful. It is so great to see people exactly where they are. And we're hoping that by the end of the webinar today, maybe we'll push the needle a little bit more. So thank you so much for answering these first initial polling questions for us. So this project was really to create sex, gender, trauma, violence, equity, and culturally informed resources that reflect women's lived and living experiences with chronic pain and prescribed opioids. And so you'll see that we brought together the research evidence, we brought in healthcare practitioner wisdom through a number of consultations and educator expertise. And then central to all of that work were the perspectives of diverse women living with chronic pain and who'd been prescribed opioids for their pain management. So I'm going to turn it over to Liv, who is going to talk a little bit about the initial research findings and how they helped bring us a little bit closer to resource development. And maybe I'll just say, as we started this project, we were really focused on what women's experiences were. And so we did have a scoping review that looked at this research question. And we found 49 articles that spoke to this experience. And Ella, I believe, will put our executive summary from that scoping review in the chat if she hasn't already. But part of that first year of this project was also to bring together women with lived and living experience. And I think it's really helpful to show some of the demographic characteristics of folks that we interviewed. We interviewed women from our 7 partners that represented pregnant people, women with mental health and substance use concerns who had experienced violence, were Indigenous, unhoused, underemployed. Um, and in the interviews, we asked women about their experiences with chronic pain and their experience with prescribed opioids. Um, and so we were able to connect with these 22 women. They ranged from 25 to 80 years old, so we had quite a span in terms of age. And women used opioids for as little as 1 month and up to 24 years. A third of the women that we interviewed were prescribed opioids for over a decade. And there were 31 primary conditions that prompted their prescriptions, and that included accidents, fibromyalgia, SI joint dysfunction, etc. But those were only the primary conditions, and so that really doesn't speak to the multitude of experiences that might have contributed to their pain or might have contributed to their prescription. And there were many co-occurring conditions that women spoke of, like migraines, undiagnosed conditions like endometriosis, and 9 of the women were still using their prescription opioid at the time of the interview. So I'll pass it to Liv now to talk a little bit about some of those findings from the scoping review and interview.
So what we found really interesting is that the scoping review and the interview findings really mirrored each other. So for the sake of this webinar, we're just going to talk about the findings combined. And so the first theme that we found demonstrated the benefits and harms. So for a lot of women, they articulated that prescribed opioids really made their pain more manageable. It helped them to numb the pain and was really helpful in taking the edge off. One of the most significant things we found, though, was that it supported them in their day-to-day activities. So being able to go to get groceries and exercise or be a parent or show up to be a friend. Those are really significant ways that opioids helped women. And they also identified that even just the act of being prescribed opioids had pain relieving qualities because they knew that on their worst debilitating days, they had something that was supportive to them. Um, Women were aware of the perceived risks of opioids, though, and were in fact quite wary of becoming dependent or addicted. And so for some women, this was actually a barrier for them that they didn't use opioids when they think they could have because they were just so concerned about the side effects of becoming addicted or dependent. We found in very rare cases, women with both chronic pain and substance use disorder reported exaggerating their pain in order to access more prescribed opioids for their substance use disorder. But this was actually very uncommon because women were, when they were aware that they were prescribed an opioid, they were very diligent and took a lot of accountability measures to make sure that they were being very diligent with their use. So women taking opioids were also more likely to have greater comorbidities than men, which we found interesting as well. And so obviously there's harms associated with opioids, but for women who found that opioids were beneficial, they reported time and again that the benefits of prescribed opioids were enormous. And despite the side effects, many women detailed how the benefits of prescription opioid use often outweighed the effects and the risks. So those who didn't find that was the case, they often just went off of opioids, but many women, such as the woman in this quote, said it was very beneficial. And so the quote says, "I think I shed a tear when I got some actual pain relief. Anytime I have a good pain relief from something, it's usually emotional, but in a good way. And I just felt like I could do things. I felt a little high or drunk, if you will. But I was, oh, wait, I can do things. I can go and run some errands and not be hating every second of this, but also, oh, this is really good pain relief." And I think that's a really good description of what we were saying because she does articulate that there was a side effect there, but the fact that she was able to live her life made that side effect worth it. So these next two themes demonstrated the profound impact of stigma and opportunities and challenges that women experience based on their geographic and social locations. These were certainly exacerbated from the COVID-19 pandemic and have manifested in really different ways. Ultimately, stigma remains a pervasive barrier to care. Some women reported shame relating to their own opioid use, as I mentioned, and stigma towards other women who use opioids, at times resulting in them suffering needlessly in pain to avoid the shame and guilt they associate with opioids. Women also reported stigma from family and friends whose understanding of prescribed opioids was only in relation to the opioid crisis and addiction. This was further heightened among women who were parents, who felt as though their ability to parent would be questioned if people knew that they were prescribed opioids. Women also reported experiencing stigma from healthcare providers. Many women described being made to feel as though they were drug seeking rather than experiencing legitimate pain that required treatment. These experiences were heightened among Black and Indigenous women of color, women in rural, remote, or northern areas, pregnant and parenting women, and the LGBTQIA plus community, women who are underemployed or unhoused, and women with disabilities. Given the biopsychosocial nature of pain, these experiences of stigma are significant because they can further perpetuate women's pain, impact her pain management plan, and the trust she has in her provider. Women may experience higher rates of chronic pain because stigma may inhibit her to access prescription opioids and related pain management strategies, and because the judgment alone may exacerbate the emotional and psychosocial pain factors she already experiences. Another theme we found related to the interaction with the healthcare system. So women described positive and challenging experiences with the healthcare system. For example, women noted that their doctors often did not give them adequate information that they needed on opioids or alternative pain solutions. For example, a study we found in Canada found that despite there being a local pain clinic available in the region and women wanting alternative to opioids, many were not offered the referral or told about the clinic earlier in their chronic pain journey. Additionally, the opioid crisis has obviously put a lot of pressure on providers to limit prescriptions for opioids and reduce their current patients' opioid medications. This has greatly impacted the ability of women with chronic pain to access opioids for pain management. For some women, it has become so hard to access opioids for pain management that they feel overwhelmed and defeated by their pain. This was also particularly challenging for women whose opioids were at a last case scenario because alternative medications and other solutions did not work for them. Women reported understanding that physicians have apprehension towards opioid prescriptions, but still do not agree that a universal approach of tapering everyone off of opioids or limiting opioid prescription is helpful. And often These interactions were conflated with complexities of women's lives, with women with certain conditions or abilities and levels of education being able to garner more trusting, non-stigmatizing care. As we found throughout the interviews and the second scoping review, self-advocacy was often described as pivotal in accessing care and pain relief, but not all women were able to do so. Women highlighted the importance of diverse care plans, collaborative non-stigmatizing care, and having her pain properly investigated. Women also reported having more trust in their healthcare team when in success in their pain reduction when there was a diverse care plan that was inclusive of not just prescription opioids, for example, but that pain clinic, like we mentioned, and heat therapy or chiropractor and massage and various other treatments. So another huge theme that came up was desire for alternatives and information needs. So there was a real desire for women to know other ways to manage their chronic pain, and that wasn't always something that came up. But women were often looking into it themselves or were able to have some conversations with their doctors. And on the left here, we note some of the things that women were using that they reported to us that really helped them. Um, and then there was also a huge uh, piece that came up relating to information needs. So self-advocacy, as we mentioned, was huge. And um, that often came as a result of women seeking for information for themselves rather than it being provided by their doctors, although they really would have wished it came from their doctors. But this was often spoken about with compassion for their providers because they know that their providers are operating under immense stress and time constraints. But women did really express that they wanted information about how to use opioids safely, to understand what are opioids and how do they impact the body, and the risks and side effects, including dependency and addiction.
You can imagine that after this first year and after the scoping review and interviews, we were quite blown away with everything we had found. And, there's really an immense sense of strength and resilience in this population. But there also was this need, and we really felt as though there was this need to explore more. And so the findings emphasized there were reasons why women use prescription opioids for pain management, including experiencing insufficient pain relief or not really knowing of the alternatives that were available. Um, but and we also found, I think, two in ways we didn't expect the benefits of using opioids for the women that we interviewed and in the scoping review, and really the impact on quality of life and mental health. But it was now up to us as researchers to look further at the research and understand these sex and gender related factors that both affect chronic pain, but also that how they impact the efficacy of chronic pain interventions for women. And so we did another two literature searches. And for those who aren't really familiar with the language of sex and gender, I've put the definitions on the screen here and I'll dive into a little bit more. Really, so we can think together about the biological aspects such as anatomy, physiology, genetics, and hormones, and how those sex specific factors affect how our pain is experienced, or sex specific chronic pain conditions. And then I know Liv has really spoken to a lot of the gendered influences, like the norms, roles, relationships, identities, and sort of the stigma that intersects because of those gendered factors, all of which really shape experiences and perceptions of pain. And I'll tell you one thing, there isn't enough research available on these two questions combined. There were only 70 articles that we had included, but really helped us understand some of the important factors that make women's chronic pain unique and really help guide our resource development. When we think about these sex related factors, such as the hormonal fluctuations, genetics, and physiological factors, we can really refer to this diagram on the screen. And so these are sort of the four quadrants of sex that we're looking at here. And pulling from one example here, I'll look at, physiology and anatomy. really just the sex differences of the physiological mechanisms of pain. And that we really were seeing like higher levels of inflammatory codeines in women with knee and hip osteoarthritis. And we also saw a lot on sort of the hormonal elements as well, and really how hormones can the moderate pain, and hormonal administration, withdrawal, and suppression can all moderate experiences of pain. And that was really seen, in research that was related to migraines and chronic headaches. We saw a lot of that, but also in other pain conditions. We also did see a number of gender-related factors, and, in terms of gender roles, we saw that these expectations around women's traditional gender norms were really impacted by chronic pain and also impacted its management. And there was a great study done by Cote and Coteau in 2010 that was looking at long-term disability in women, and they found that women who had long-term disability from work experienced domestic strain, social isolation, and really emphasized the impact of their traditional duties or domestic duties on their ability to participate in rehab, whereas men who were also on long-term disability reported having ample time to spend on rehabilitation. So, sort of these roles and how they influence. And similarly, in that study, they saw institutionally that even though women dominated employment sectors might have higher levels of musculoskeletal pain, um, that women really struggled to get their pain acknowledged and really struggled to get benefits from the workers' compensation system. So there are lots of ways in which gender affects beyond how we typically refer to gender, just in terms of gender identity. So it was really helpful to think about how we can sort of port our practice, and we'll take the next, 20 or so minutes to talk about a number of these resources before we jump into the Q&A. But please, we encourage as we go, if you have questions, type them in and we will answer them at the end. So Liv, I'll pass it to you.
Great. Yes. So yeah, with all of the information that we just presented to you, and the information needs that women articulated to us, and then consultations that we had with healthcare providers and various other people, we developed some resources that we're really excited to share with you. Um, so we'll jump into the first one. So this sheet here, it's a longer infographic you can see in the right corner, the full sheet. It is kind of a general and punchy version of a lot of the content that we have in the rest of our resources. It overviews kind of the key facts that we found in our project, the key things that we want providers to understand, and then 5 ways to take actions about it. So you can see, or sorry, 4 ways to take actions about it. You can see 1 to 4. That women report higher rates of chronic pain than men, biology affects chronic pain, societal expectations of women affect experiences of chronic pain, women's chronic pain is often dismissed. And then the 4 ideas for actions are involve women in decisions about treatment, know that women feel prescription opioids have a role, provide more information about prescription opioids, and hold empowering conversations about comprehensive options. So as I'm sure you can tell, this really does reflect a lot of the information that we just presented to you on our findings. And we also think that this has the opportunity to be a very good self-advocacy tool for women, and as they navigate their understanding of how they should receive treatment for their chronic pain. So it's really a resource that is accessible for various people. This one is an infographic that highlights 9 chronic pain conditions that disproportionately affect women. It can be used by educators, health and social service providers, policymakers, and people who've lived in living experience. I know for sure by looking at this as somebody who lives with chronic pain that it's really valuable to see this as as a woman myself who's had my pain dismissed, it's helpful to see my pain conditions on there and recognize that my experiences are seen in this research way. So this is also something for women to see themselves. So it can be found as a standalone infographic, as you see here, but is also embedded into various other resources that we'll be showing you. So I wanted to highlight a couple of things that we have on the sheet. So like Lindsay was saying, due to fluctuations of hormones during the menstrual cycle, women are 3 times more likely to develop migraines than men. So in Canada, there are approximately 2.8 million women living with migraines. And it's endometriosis month, and endometriosis is a chronic pain condition that is disproportionately experienced by females, or almost solely, you could argue. And 10% of women and girls live with endometriosis in Canada, and that is equivalent to 1 million. So yeah, we just have some little facts on here for each of those conditions and how it shows up for women in Canada. So this is a 2-page sheet for health and social service providers that can be used in conversation with women. But I think it also is really important in reflecting that information need that we highlighted earlier, that women want to know about prescription opioids and how it affects them and the side effects and dependencies. And, usually when women are prescribed a prescription opioids, and if they are told side effects, there's not really that sex and gender element to it. So this sheet really goes into some research on how prescription opioids specifically impacts women's health. So you can see there's various things here relating to chronic pain and the intersection of prescription opioids. But some of the information that comes on this sheet is how females experience opioids differently, and that long-term use can impact hormones, fertility, anxiety, and depression. We talk a little bit about side effects, and we also talk about why women may choose to use prescription opioids, such as the reduction of pain may help them return to day-to-day activities and work, such as we mentioned to you earlier. So this sheet is a conversation that providers can have with women, but it's also something that women can read themselves to understand what prescription opioids are and really how they'll impact them and the benefits and harms.
These next two sheets are really all about treatment and pain reduction strategies. And creating resources that highlight evidence pathways is such an interesting process because they don't always encompass the biopsychosocial nature of pain. And I'm so relieved that we're starting to see a difference in sort of how pain is understood in the research and therefore how we're able to translate it. This first sheet looked at the most evidence treatments for women's chronic pain. So, taking into account sort of how those sex and gender factors impact the efficacy of chronic pain. These were 8 of the most evidence treatments um, that we found. And it's so wonderful that we have interdisciplinary pain programs at the top, which do take into account the multifaceted nature of pain. And in that top 8, we also see things like time, mindfulness, and cognitive behavioral therapy. And I don't really think we see these approaches talked about enough. Um, and we showed these, if you remember at the beginning of the webinar, we talked about sort of who all has been involved, and we showed this first infographic in a consultation with healthcare providers. And some of the feedback we heard was that it's great to have these that are solely based on the research evidence, but finding ways to make them more encompassing. And so we have this second version that's also available that takes 3 pages. Um, for folks who are experiencing pain and for health and social service providers that really thinks about these multifaceted components of pain. And we offer a description of each of the strategies that's listed on that right hand side, but also examples of how it's been applied for pain management and what it's been helpful for. And so, I'll show you sort of the in between sheets of it, but you can see that these range from medical interventions such as surgery, Botox, spinal cord stimulation, to also thinking about cultural practices like land based healing, smudging, TCM, and psychosocial supports. Um, it's also just really lovely that we do see time, and I think maybe that's uh, a unexpected practice to see on both of these sheets, but really building on the evidence that says time really can contribute to a reduction in chronic pain. And that might be because of increased development of coping strategies. It might be a reduction of pain. It might be opportunities for healing. But that time can really help with the healing process and with pain reduction. But this is, yeah, just a 3-page infographic that does pull into a lot of these examples here, and can be used similarly as sort of a self-advocacy tool to think about, what is in your pain reduction toolbox if you're somebody with chronic pain. What strategies have you used? And many of these strategies can be used together. And so, sort of like, what strategies here do address the multifaceted components of pain, the social components of pain, the biological, the psychological, all of that. But they also can be used by providers who, have are really navigating with short appointment times and um, complexities of pain, and it is complex. And so seeing these strategies all laid out, all of them being evidence-based, sort of giving a menu, which I think is just such a fun opportunity and an exciting opportunity that has diverted a bit from what we have previously seen.
So we're creating kind of short but kind of long 5 to 7 page information packages for both women and service providers. And I saw the question in the chat that spoke to how do I, your doctor is opposed to having or prescribing opioids. And that's really what a lot of our resources are trying to identify is like how do we help providers understand the place of opioids and how women use opioids. And so the information package for providers is really going to be unpacking women in chronic pain and prescription opioids and the research we found, and then how prescription opioid use is even a better tool when it's paired with a comprehensive women-centered pain management program. So that's what we're kind of making for the providers. And for women, we're creating more of a package of, again, information needs and understanding. What is their chronic pain? Why do women experience more chronic pain than men? What are opioids? And what are strategies that they can use to manage their chronic pain? So it's both kind of a, again, self-advocacy resource and also something that they can learn to kind of do self-coping on their own time or learn a little bit more about themselves. And so these packages are currently in the works. They're being reworked and they'll be available by the end of March. So for sure, keep an eye out, and we'll send those with the webinar follow-up email, I believe. And one of our last resources that's pretty exciting is we've been creating this online education guide that is a lot more, everything that we've talked about today and more unpacked for, policymakers, healthcare providers, researchers, anyone who wants to know about sex, gender, women, chronic pain, prescription opioid use, and everything that we've talked about. All of the resources today that we've talked about will be embedded on this. But it's really a educational guide to help understand and support people who interact with women with chronic pain, to understand how to, approach care in a women comprehensive or a women-centered comprehensive way. So as I mentioned, we include a lot of the resources that we've already mentioned to you, but we expand on the information to offer more information on reflecting on stigma and prescribed opioids and diving into comprehensive care for women specifically, and taking into account these values on the right. You can see we have a little graphic there of women plus comprehensive or women plus centered care. I always say comprehensive because I do think the two really go together. And yeah, just we also mentioned some approaches that can be used, like motivational interviewing and trauma-informed care to facilitate interactions with women. So we're really excited about this, and it's going to be free and it's going to be on our website. So that will also be something to keep your eyes out. And um, that will be coming the end of March, I believe, as well.
And lastly, we didn't forget about those of you who mentioned that you're in policymakers in the room, but we have a resource specifically for you. The final component of this project was really to think about and augment the pain action plan using SGBA plus. And for those who aren't familiar with SGBA plus, this is a process to assess how different factors such as sex, gender, age, race, experiences of colonization, etc., may be impacted by an experience, program, or policy. And so we looked at the Pain Action Plan goals and applied SGBA and looked at these. uh, Um, we really wanted to highlight our findings on improving the response for females and women who continue to be under researched and undertreated. And so, looking at these goals on the left here, specifically on having equitable and consistent access to a continuum of care, having increased knowledge, skills, and supports for people living with pain and also health professionals to have infrastructure and data that allows us to improve health system inequities and improving equitable access to populations disproportionately affected by pain, for which women is one of them. We looked at all of these and then took into account gender factors because gender biases can create inequities in care and perpetuate assumptions about co-occurring health concerns and pain tolerance. We thought about sex related factors such as the hormonal patterns that we spoke about because they really impact the prevalence of conditions. And then we brought in equity considerations as well, so that way we can be dually responsive to age, disability, sexual orientation, gender identity, race, etc., as we hold sex and gender. And so, in this response to the pain action plan, you'll really see that we lay out why sex matters, why gender matters, and why equity related influences must always be considered as well. And so, this is a final sheet that will be distributed when we send out the slides, and the recording will send a full package of the resources that we talked about today.